Hi, I'm Dr. Jeffrey Cantor from the Cantor Spine Center at the Paley Institute. And what I want to do today is take a little bit of a deep dive into a problem that I see patients with on a regular basis, and is one of the most common problems that we see and treat, and it's very poorly understood by our patients and by the general public overall. And that problem is called cervical stenosis. And we see patients on a regular basis that are told they need surgery, that sometimes it's an emergency, and they come in and say, I don't really have any pain, I have these little tingles, and I don't really know why. I'm getting conflicting opinions. One doctor says it's an emergency, the other doctor says wait till it gets worse. And what I want to do is make you have an understanding of what cervical stenosis is, why it's potentially a problem, and it's important to understand that cervical stenosis is the most common reason for quadriplegia, for losing the ability to walk and losing the ability to use the arms and legs and other functions of the body in folks over about 65 years old. So it is a real issue, and it's something that really is important to understand a little bit better. So if you're told you have cervical stenosis, it's a good idea to watch this and try to understand it. So what does the term stenosis mean? The body has pipes, has tubes, blood vessels, the spinal canal. Things travel through conduit within the body. And the term stenosis simply means when something starts to plug up those tubes. So anything that gets into these tubes, whether it's cholesterol or bone, can compromise the inside of these channels. And when it does, these channels can get blocked. And that's the main reason for coronary artery disease. The blood vessels, the tubes, start to get obstructed. And arthritis in the spine can also grow into the channels where the nerves travel through and cause a narrowing, and that narrowing is called stenosis. So what does that look like? So this is an example of a spine, a MRI scan of a spine in the neck. Looking at a side view, you see the bones that stack on top of each other, and inside the bones there's a canal, a conduit that the nerves travel through. So if you look at that conduit, what you can see is there's a channel, and that channel has plenty of room. And the spinal cord is this structure that goes through the center. And in front of it and in back of it, there's white, and that white is fluid. It's space. And this is an example here of another individual that instead of having a nice clean line, all of this stuff has grown into the canal, and instead of the spinal cord having plenty of room, you can clearly see between here and here it's severely pinched. That's cervical stenosis, and what it's doing is it's pinching the spinal cord that travels through that tube. So why is this important? And a lot of you follow professional athletics, and there's a lot of discussion these days about concussions in athletes, and we know that when you bump into the brain, when you impact the brain gets damaged. It actually disappears. And if you hit the brain enough time, you can lose enough brain where you have difficulty thinking. So the NFL has spent billions of dollars investing into looking at ways that they can identify players that are developing brain injuries and alter that process. What's really important to know that the spinal cord is basically an extension of the brain. This is the base of the skull, the face is here, and there's a hole at the base of the skull called the foramen magnum. And the brain travels through that hole, and below this point, the brain turns into the spinal cord. It's the same structure. So above the base of the skull, this structure is called brain. Below the base of the skull, it's called spinal cord. It's the same thing. It's not like one's a liver and one's a kidney. It's an extension of the same structure. So why is that important? Well, that the brain is very delicate, and when it gets bumped into it gets damaged. The spinal cord will do the same thing. Also notice that there is water, there's space around the brain. This white stuff is water. It's called spinal fluid. In the skull, the brain floats in water inside a space. It doesn't actually come in contact with the bones. When you whack into it, that impact goes across the water and actually can damage the nerves without even physically touching the bone. In the spinal canal, there's also water. And in the spinal canal, you have a flexible group of bones. And that flexible group of bones is moving around the nerves. So you have a tube, the nerve's in the center, and when you move your head, the bones move around your cord. They don't come in contact with it. When they do start to come in contact with the spinal cord, and when something comes in contact with the brain, it will damage it. When brain and spinal cord get damaged, they disappear. They literally turn into liquid. And that is visible on an MRI scan. So you can actually quantitate with traditional MRI scans damage to the brain and damage to the spinal cord. And we'll discuss a little bit later some of the more advanced ways of quantifying that. So again, the brain and the spinal cord are the same structure, extremely delicate, need to be protected. When they're unprotected, they can get damaged. So why is that important? It's important because the body has a certain amount of tissue, and in the situation of the nervous system, that tissue is you're born with a certain amount and that's all you get. Normally, again, you're born with 100% of your spinal cord. Over time, that's going to degenerate, and you're going to lose enough cord where at some point in time it may be difficult to do things like walk. And the usual amount of time that takes is about 85 years. So we see a lot of folks 85 and up that are really starting to stumble, starting to have trouble walking. And that can be natural attrition to the spinal cord where they really just don't have enough left to do the functions that they need. A lot of people don't know that's happening, and we're going to describe why in a minute. But this process is ongoing every day. Now, if we bump into the spinal cord, if we bang into it on a regular basis or one really big time, we can speed up this process a lot. So instead of having difficulty walking when we're 85 years old, we'll develop difficulty walking a lot younger. So the process of stenosis that pinches the cord speeds up the process of damage to the cord, of the natural attrition. And instead of having a normal lifespan of our nervous system, we can really decrease that lifespan where when we're 50 years old, we're starting to have trouble walking, and when we're 60 years old, we might lose our ability to walk completely. So why is this unnoticed? And the process is called neuroplasticity. And what neuroplasticity is the brain's ability to adapt and the spinal cord's ability to adapt to damage. Nova did a really nice description and a really nice show a couple years ago on neuroplasticity. If you want to dive into that a little bit more, the PBS Nova TV show has a great description of what this is. But in a really short description, the spinal cord is made of billions and billions of cells. And for make it simple, that's going to be 1 billion cells. And for argument's sake, this area right here is the part of the spinal cord that's responsible, say, for moving your right arm. When we develop stenosis and we start to bump into this, what happens is those cells, as I mentioned earlier, they disappear, they liquefy, they get damaged. Now, if they get damaged really fast and we lose a bunch of these cells, we can lose the ability to use our right arm. So if we really whack our spinal cord, get in an accident, a football injury or something like that, and you see football players get really badly injured, they become quadriplegic, and then a couple weeks later they get better, it's because they only damaged an area of the spinal cord and they have the ability to recover. So the brain will actually learn this function and it will transfer it over to other nerves. So now, instead of using this part of the brain to use your arm, you're using this part of the brain. So as long as the rate of damage doesn't exceed the rate that you can learn and recover, you don't know this is happening. It's completely unnoticed, and patients can go on for 50, 60 years with cervical stenosis and all of a sudden someday stop walking. So why does that happen? So as I mentioned, as long as the rate of damage exceeds the rate of recovery, or the rate of recovery exceeds the rate of damage, we can basically compensate for this. But when we get to the point where we don't have anything left, as we lose more cells, we can't recover anymore, and that's when we start to lose function. And if you go back to the previous slide, that's when we get to the point where we're kind of out of gas. So the spinal cord has lost enough tissue where it really doesn't have anything to recover anymore, and then we start to stumble and start to fall and start to lose dexterity. What are the symptoms of cervical stenosis? How does the patient know they have it? And they can vary dramatically. Some patients come in with very little symptoms at all. Some patients come in with excruciating pain. And it can vary from extreme symptoms to no symptoms. And interestingly, the patient that has no symptoms might be in a worse situation. So this is a picture of a cadaver specimen of a cervical spine. And if you look from the side, the base of the skull and the bones in the neck, and if we turn this over on end, this is what we're looking at. The bones in the front called the vertebral body is here. The arch of bone that covers the spinal canal is back here. And the spinal canal through which the spinal cord travels is here. And also what's really important to see is the amount of space between the bone and the spinal cord. And that space is full of water. The spinal cord also has nerve roots that come off the cord that function very differently. This is a different graphic of basically the same structure that might be a little bit easier to understand. The spinal cord itself in the center has no sensation. Very similar to the brain, when you actually have the brain exposed during surgery, the patient can be awake with no pain. And the spinal cord, again, is an extension of the brain. So when you touch the spinal cord, you can damage it with no sensation. So when bone or stenosis is growing into the area and pinching the spinal cord, you can damage the cord with very little pain or very little discomfort. As we lose cells, we can start losing dexterity. As we lose the ability of the cables within the cord to conduct signals, we start to notice changes in our ability to manipulate our hands, to navigate when we walk, and to do fine motor skills. So we might see changes in dexterity and no pain. The spinal cord also has branches that come off the cord, and these branches form what's called nerve roots. So at every level, nerves come out of the spinal cord and go into the arms, and they go into the arms through what's called foramina, and that's these holes off to the side. And what's really important to know is these nerves are extremely sensitive. So pressure pushing on the cord itself can cause damage with no pain, but when a stenosis forms off to the side and pinches the nerve roots, that causes severe pain. It can cause neck pain, it can cause arm pain, it can cause pain in the whole body, or all the above. So the reason the symptoms are so variable in cervical stenosis is depending on where the bone is growing and where the stenosis is forming, it will cause either pressure on the spinal cord, pressure on the nerve roots called foraminal stenosis, or both. Pressure on the spinal cord typically is the more dangerous problem, but typically the least easy to notice and to understand. How does this form? How do we get cervical stenosis? How do we develop stenosis in the spinal canal in general? And the basic process in the majority of cases is related to arthritis. And what happens is, as the body develops arthritis, and this is an example of any joint, this could be your knuckle, it could be your knee, it could be the joints in the neck. And what happens when we develop arthritis, our bones expand. The outer part of the bone around the joint will start to get bigger. Now, if this is a finger, it just gets bigger. But in the spine, when the nerves are traveling past here, these bone spurs are going to grow into this space and actually come in contact with the nerves. So arthritis is the most common process depositing bone. That bone starts to encroach into the spaces that are normally occupied by delicate nerves, causing either damage to the nerves, pain, or pain and loss of function. Once again, we showed this slide earlier, but this again is an example of the bones nice and clean with a very large channel with the cord traveling through and fluid in the front and back. And here you can see the normal area of the bones, and you can see the arthritis bone spurs forming, and that formation in both directions is severely pinching the spinal cord. So the underlying reason for stenosis in the vast majority of cases is arthritis, and there's a number of different types. Spondylosis is the general term for arthritis. There's something called ossification of the posterior longitudinal ligament. There's a number of different types of arthritis, but in general, deposit of tissue in the spinal canal due to arthritis is the most common source of this problem. And this is a cross-section view looking at the spinal canal on end. Once again, the vertebral body in the front, the plenty of space around the spinal cord, the room around the cord with the cord in the center, almost like a fried egg. And here you can see a different patient where you have this big bone spur and the spinal cord, instead of having plenty of room, is just squashed inside that spinal canal. So here is a normal spine. Here is arthritis growing into the spinal canal, causing severe spinal stenosis. When does this become important? So there are a lot of patients come in and they have no symptoms, mild symptoms, are told, hey, you need to have an emergency surgery, you might not walk someday. Other folks are told not to have surgery. So it's been difficult, and a lot of patients can have stenosis for their whole life and never get into trouble. You can have quite severe stenosis and never have a problem. Or you can have severe stenosis and one day you're walking just fine, the next day you sneeze and you can't walk at all. So can we predict? And there's been a lot of studies done, there's been a lot of ways of looking at the basic anatomy, the structure, the sizes and the spaces available, trying to predict who's going to get into trouble and who's not. And what I'm going to do with this slide is go over the basics of what those parameters are, and they're not very accurate. They're kind of guesses, which is really what makes it difficult to determine this. So once again, we have the same basic slide, and we have from the front of the channel to the back of the channel is the diameter of how much space there is for the cord in the center. And normally that diameter is about 12 to 14 millimeters. The spinal cord itself is usually about 8 to 9 millimeters, and there's a tube around the front and the back of it that's about a half a millimeter on both sides. So the space necessary for the cord and the bag that it sits in is about 10 millimeters. So with 12 to 14 being normal, 10 is about the size that the spinal canal is starting to get small, where the bone is actually coming in contact with the cord. The definition of stenosis in textbooks is anything less than or equal to 10 millimeters. But in most patients, it's not a problem. So in patients that don't have hypermobility or joints that are loose, and some people do, but it's pretty rare, and that's a separate discussion. But in most patients that have normal structure to their spine and normal structure to their neck, if you follow these people for a long time, they don't get in trouble. So even though 10 millimeters is described as the threshold for what is called stenosis, sometimes it might cause some discomfort, but very rarely is this dangerous. There are cases that there may be variability to that. 8 millimeters is about the size when we start to get concerned. About 1 in 3 patients that have a canal that's 8 millimeters will start to get into trouble. And interestingly, the patients that are already having problems when that diagnosis, when that measurement is made, are the ones more likely to get into troubles. So out of 3 patients, 1 will likely progress and about 2 won't. So the question is, what do you do? If you have an 8 millimeter canal and you don't have a lot of symptoms, what do we do? Well, in the past, if you didn't have signs of cord damage, and that's something that needs to be determined by somebody who really understands this. If you don't have signs of what's called long track signs, we typically will follow the patients. We'll re-examine them in a couple of months and maybe even after they're normal again a couple of years. But we really can't predict who's going to get into trouble. It's kind of a guessing game. 1 in 3 is going to be in trouble, 2 in 3 is not. We really don't know who's going to have a problem. So if you have symptoms and you're 8 millimeters, we'll often recommend doing something about it to open it up and surgically fix it. And if you don't have symptoms, we usually will recommend at that point in the old process to watch it. 6 millimeters or less is really a problem. It's dangerous. There's so much pressure on the cord that it's very likely to cause problems at a rate that might be dangerous. And a lot of patients at 6 millimeters, even the ones that don't have trouble, will get into trouble. So at 6 millimeters, we usually recommend some sort of a treatment. So these are basic numbers. These are an overall kind of a guess of where you're going to be. Now, if patients have symptoms, if you're having progressive difficulty with dexterity, progressive difficulty with balance, if you're noticing that when you're walking up steps, you're having more and more trouble navigating, when you walk and you change directions, you feel like you might fall, if you're getting numbness in the hands, when you move your neck, if you're starting to notice shocks and tingles in the arms, or if you're having significant pain, these parameters are a little bit less important, because then once you're really significantly symptomatic, surgery is more of a necessity. Now, it's also important to know that patients who do have cervical stenosis causing damage to the cord called myelopathy, surgical solutions do better than non-surgically treated patients. So if you have cervical stenosis and you are getting worse, or you have a significant problem on an exam done by somebody who really knows how to look at that problem, if you treat it, you will likely do a lot better than not treating it long term. Also, it's important to know the longer you wait and the worse the problem, the potentially more dangerous to treatment. Patients who have a relatively healthy cord that's getting damaged early, if the canal is opened, they do better than if they wait till they're really in trouble because of the potential issues associated with the surgery themselves. And we're going to discuss that in a few minutes. So these are two examples of patients with cervical stenosis, and interestingly, this one looks quite severe and this one looks quite mild. This individual has no symptoms other than some mild tingles in the fingers. This is an elite athlete who, every time she moves her neck, every time she jumps into a pool, every time she does something active, gets exquisite tingles and numbness in her arms, almost feels like she's getting electrical shocks in her arms and legs, and is slowly but progressively losing strength in her arms and legs. So this is a patient who's a lot older, in their early 60s. This is a patient in their early 50s. This person's much more symptomatic, and if you look at this one, you'd expect this patient to have much more severe problems. And that goes back to the rate of loss versus the rate of recovery. And as I mentioned earlier, spinal cord disease causes damage to the cord, and it causes the cord to liquefy. This is white of spinal fluid. The gray is the actual nerve cells, and when this cord gets damaged, it turns into water. Water's white, and if you look at these areas here, you can see white spots within the cord. Now that's visible cord damage. That's enough of the actual spinal cord has been damaged and disappeared and liquefied where you could actually see it. That's called myelomalacia. Myelomalacia is a bad sign, but what it also shows is this process is very slow. This is somebody who's losing cells, and as they're losing cells, they're recovering at a rate that doesn't allow this to be noticed. So you're developing cord disease, but you don't know it. This is quite significant, and I would say that most surgeons would look at a neck like that, and if it's a healthy patient, would recommend fixing it, because this is somebody who can fall off the edge. This is somebody who can be going around just fine and look up to watch an airplane and fall to the ground and never move again. So this is one of those patients where somebody says, hey, if you get in a car accident, you can become paralyzed. It's not that common, but what is common is once you get to the point where there's visible damage to the cord, it's likely to progress. So if you're active, if you're athletic, if you're somebody who likes to ride a bike, if you like to ski, if you like to do things and you have a spinal canal that looks like that, that's potentially dangerous. Going to this patient, what's happening is, even though the stenosis is mild, and what's also interesting is, if you measure the spinal canal, it's about 10 millimeters, maybe a little bit less. So it doesn't meet the criteria for severe stenosis. This individual has mobility of the bones where the bones are moving relative to one another and they're actually bumping into the cord. And when they're doing that, it's kind of like having concussions. It's like getting hit in the head. And when that happens, it's whacking into the cord and causing significant damage. So the difference between this person and this one is, even though this looks less severe, the impact is causing a more rapid degeneration of the spinal cord nerves. And the degeneration is exceeding the ability of the nerves to recover. So even though they may have less damage here, the body can't recover fast enough, so it's more symptomatic. So also what's important here is the ability to determine whether or not this individual does in fact have a problem related to stenosis. Now in the past, if you just look at the measurements, the guessing measurements that we looked at before, this is obviously a problem and this is not. This is new. This is exciting stuff, and this is a very, very different way of looking at the spinal cord. And a lot of the research and a lot of the technology that is leading to this new technique called diffusion imaging actually comes from the NFL and comes from the necessity to look at brains and determine how much damage there is. So what this is what's called a diffusion MRI, and this is a standard MRI. And what this is looking at is, here's the brain, and again the spinal cord, and this picture, the spinal cord looks like a gray tube. You can't see the nerves, you can't see how many nerves there are, you can't see if there's any damage to the nerves. You can just see the spinal cord, kind of a shadow of it. This is diffusion imaging, and what this shows, this structure here is this. And what it shows is all of these fibers. These are actually the nerves. This shows us a healthy spinal cord. So what we're looking at here is a very wide open spinal canal, the spinal nerves traveling through, and what it looks like when they're normal. What diffusion imaging does, it's a rapid MRI scan that actually can track water molecules flowing through the neurons. And the neurons are like hoses, they're pipes. And the MRI scan can detect the direction of the water molecules. So when the nerves are not damaged, it's going to flow through the nerves in a nice straight line like the mane of a horse. When the nerves start to get damaged, it's going to start to get frayed, and you're going to start to lose that very clean look. This is what diffusion imaging looks like on end. So side view, this is an end-on view. And when we look at the nerves, a normal spinal cord is going to be completely red. That shows that all the water, all the tubes, all the hoses are flowing water in the same direction. Around the outside, you see a little bit of yellow and green. Yellow is a little bit of turbulence. Green is actually not normal flow, and that's actually getting into the area around the cord where the spinal fluid is. But inside the spinal cord, you should see red or red and yellow. Once you start seeing in this particular color sequence, greens and blues, that's where the spinal cord is getting damaged. And again, this is the long view. This is the view where it's cut in half, looking at it on end. So this is an example of a normal spinal cord, and this is what a spinal cord looks like when it's damaged. So this is somebody that we can actually look into their cord and say, hey, you've got some stenosis, but your cord is pretty healthy, versus you're starting to get into trouble. We can quantitatively know, are you starting to get to the point where this might be dangerous? So two more patients, two more examples. This is an individual with relatively severe stenosis, was sent here for surgery but doesn't have any symptoms. This is the same patient that we looked at before. Doesn't really have severe stenosis visibly, but has a lot of symptoms. So if we look at their diffusion MRI scans, this initial patient with what was thought to be significant stenosis has a healthy spinal cord. This person doesn't need surgery. It probably doesn't even need to be watched very frequently. The cord is healthy, even though the bone is growing into the canal, it's not causing significant damage. This is the patient that was a little bit confusing, where there's a lot of symptoms, but there isn't severe pressure. But if we look at the actual nerves themselves, what we can see is severe damage. The cord, instead of being nice, healthy, is frayed. It's called anisotropy, and that shows that the spinal nerves, instead of the fluid flowing in one direction, is leaking out, kind of like if you run over your hose too many times in the driveway. How is cervical stenosis treated? And In patients that get to the point where it's been deemed necessary that it needs to be fixed, they clearly understand what's going on and clearly understand the options. There's a sequence of how this disease has been treated. And we're going to go through a kind of a linear progression of how cervical stenosis has been treated, some of the older techniques, some of the new technologies, and some of the newer techniques. And initially, the way that cervical stenosis was treated was called a laminectomy. And a laminectomy simply means to remove the cover. So if we look at this from the side, and what we see is the cord getting pinched from below there to above there, something has to be done to open up that channel. And with traditional techniques, either we go from the front of the neck, we take the bones out, we remove them, put a long spacer in or a number of spacers, and we do what's called a fusion. So we remove the pressure on the cord from the front, and we essentially open up the channel by taking all of this stuff out. The older solution is going from the back of the neck and taking the covers off. And these covers are called lamina, and the early operation is called a laminectomy. So if we turn this on end, we see the same thing. So from the front of the neck, we would remove the bone spurs and open up this channel. And from the back of the neck, we would basically cut this arch off and essentially just open it wide open. And that seemed like a good idea, but laminectomy is associated with a significant number of problems. And one of the problems associated with laminectomy is when we do the procedure and the head is upright before the operation, about 1 in 3 patients will end up with the head falling down. And once that happens, it's really not fixable. And it's a big problem. It's certainly difficult to go through the rest of your life looking at your feet. So this is called post-laminectomy kyphosis, and there's a reason for it. With traditional techniques and traditional technologies, it's kind of difficult to prevent this. So why does this happen? Why do we get a post-laminectomy kyphosis? Why does the head fall down after a procedure? And the answer is in the structure that holds the head up. If you touch the back of your head, there's a bump, and if you slide down, there's a second bump. And those two bumps connect to a ligament, a cable. Here's the bump in the back of your head. Here's the attachment to what's called the C7 spinous process. This is called the nuchal ligament, and that holds your head up. That happens to be attached to the lamina. The lamina that we remove in a laminectomy eliminate this cable. And when that cable is eliminated, the head falls down. And it happens frequently enough where we've had to develop, surgeons have had to develop techniques to rebuild what was taken out. So if you look at a bridge and you put the spine sideways, the tip of C7 is here, and the back of the skull is here, and the cable goes from one stanchion to the other. If you remove either one of these, the bridge is going to end up in the water, which again is the same thing that happens when you do a laminectomy and you remove these attachments to these cables. This is the result. What has been done to remedy this problem is we use what's called fusions. So when we take the structure out, we rebuild it. And when we go from the front of the neck, we take the bones out, we replace them with either long struts of bone or individual small bones, and then we put a plate and we hold the bones together with plates and screws, and it allows the structure that we removed to regrow. It doesn't regrow normal, it regrows in a solid piece, so each individual bone that moved before is no longer moving. The challenge with fusions and the problem with fusions is we take all the mobility that was normally in this area and shift it above and below. So the motion that is lost in this area now has to be taken up by this joint, and they weren't designed to handle that much stress. When we do fusions, we transfer stress above and below, and that increases the rate of arthritis at the adjacent joints. If you normally form stenosis and we increase the stress on the adjacent joints by doing a fusion, what's going to happen is you're going to increase the rate of arthritis at the joints above and below the fusion, and you're going to have a recurrence of the same problem. So fusions particularly when they're more than 2 levels, lead to increase in stresses and typically lead to additional fusions. So when you fuse one area, you're going to probably fuse the next one and the next one and the next one. And at some point in time, you're going to kind of run out of space, and then we're in a bad spot. So even though fusions are very effective operations at getting rid of stenosis, they do tend to lead to additional surgeries, limited mobility, and potential problems down the road. And this is another example of an individual with a fusion and severe stenosis, even life-threatening stenosis at the next level. The other options for fusions is to do the fusion from the back of the neck. Now this is a large, almost a 10-inch incision, and because we take the ligament out, we have to replace it. And we replace it with screws and rods. Now again, a very effective way at treating the stenosis, but a very ineffective way at maintaining function, mobility, and lifestyle. So most patients who have stenosis that had numbness and tingling and maybe some trouble walking, when we do this operation, we can often help them a lot. But if you ask them a year later, are they happy with the operation, a lot of them would say they wish they had never done it. Because of the limitation of mobility, it also causes consistently significant neck pain, and you'll never get the muscles that normally move the head back where they're supposed to be, so a lot of strain, a lot of achiness, and a lot of discomfort after these operations. This is an operation that I used to teach. I do it very rarely because of the fact that most patients who've had this operation really don't like it. So there's a new technology that really has changed things. And the new technology is called ultrasonics. And this is an older tool that we use to cut bone. It's similar to a Dremel. It's sharp, it spins, it tears, and on bone it very effectively cuts. But when you put it next to something soft, it's pretty dangerous. This is an ultrasonic tool. It uses vibration. It's more powerful than the cutting tool. It'll go through plastic and bone a lot faster than the traditional tool, but because it's not sharp and because it doesn't spin, it's very safe around delicate structures. You can barely pop the balloon if you try to with this. So this can be used in direct contact with nerves. You can actually physically touch a nerve with this tool if you know how to do it. It's not simple to use. And you can work in very, very small incisions. So why is that important? It allows us to use procedures that do not damage normal tissues. So through an incision about that big versus an incision that's 10 inches, we can remove all the pressure of the nerves without interfering with any of the normal structures. So the cables that hold the head up are not interfered with. And because they're not interfered with, we don't have to rebuild them. So by using ultrasonics and by using techniques where we work under the ligaments and we preserve their attachments and we preserve their normal mechanics, and we're now actually reinforcing those ligaments with different suture techniques, we can fix the neck without causing additional damage. Now that's important because this is a patient before surgery and after surgery, and other than the fact that you can see that the spinal canal is small here and much bigger here, meaning that the cord has plenty of room here and doesn't have any room here, this looks pretty much the same as that. So essentially what this has done is just plastically reshape the bones from the inside out, saving all the ligaments. No need for screws, no need for rods, no need for fusions, no stress transfers. So the probability of needing additional surgery is much, much lower. It's about 1% at about 15 years versus almost 15 to 30% per year with more than a 3-level fusion. So these operations preserve function, preserve mobility, and this is something that can be used to intervene a bit earlier with because it does offer a better lifestyle option. So say, let's wait till you can't walk but to fix your stenosis that in the past used to be not unreasonable, now is less reasonable because we have better options for treatment. Once again, this is a comparison between the typical anterior fusion, where structure has been removed and rebuilt with anterior plates, or plates and screws in the front of the neck. Probability of adjacent level stenosis is quite high. This is a traditional operation done from the back of the neck, or a posterior fusion where the ligaments were removed. These screws and rods are replacing the ligament to hold the head up. And this is a newer technique where the decompression, the pressure removed from the spinal cord, can be done inside and under the ligaments without interfering to their normal attachments, and therefore they don't have to be rebuilt with screws, rods, and fusions. A much better option. Now, what's also important to understand is these are one type of stenosis. There are many different situations. Operations have to be mixed and matched. In other words, sometimes we'll do a plastic operation with a single level fusion versus a multiple level fusion. So we will decide which patient has what their individual situation is, and we do an operation that saves whatever is working for them and whatever is good, and we replace and we repair what's not good, as opposed to essentially fixing the whole thing and then just rebuilding it with metal. So I hope this was helpful. I hope you're a little bit better informed about cervical stenosis, what it is, what some of the treatments are. It was a little bit of a deep dive, but there's still a lot more detail. Patients have stenosis with associated deformity where their head may not be in the right position, things like that, which makes it a bit more complicated. This isn't a one-size-fits-all. This is just a brief overview of what stenosis is, why it potentially can be dangerous and problematic, and should you or should you not consider surgery. If you want to have somebody take a look at it, if you want us to talk to you about this, feel free to call us. And again, hopefully this was something that was useful to you. Thanks so much for watching.